Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today, we welcome back Joseph Parker. He's a research physician. Today's Kevin MD article is titled Codeine Cough Syrup, a Controversial Classification. Joseph, welcome back to the show.
Thank you, sir.
So Joseph has been on multiple times. Just go to kevinmd.com/podcast, upper right-hand corner, search icon, search for his last episodes and hear his story. But today, let's jump right into today's article about codeine cough syrup. So how did this article come together?
I had been unaware that codeine cough syrup had become popular in a few segments of the population. I'd been using it for 30 years. It's a very effective cough syrup. Codeine, it gets converted into morphine at sort of a slow rate in the liver. And this allowed you to prescribe the codeine cough syrup, and the patient would get a tiny dose of morphine, and morphine's the best antitussive we have. And so we had been using it for 30 years with no problem at all. And then all of a sudden you see physicians being prosecuted for prescribing it. And when they're prosecuted, the DEA claims in court that it has a high addiction potential and a high diversion potential. And I have a big problem with that because it's classified as a Schedule 5 when it's codeine with promethazine cough syrup, which is what they're upset about.
So tell me about some of these individuals that you've heard been prosecuted for prescribing codeine
I'm
cough
one
syrup.
of them. I'm one of them. So I was charged for prescribing. I had, over a 2-year period, I had treated 29 people with this cough syrup in total, over 2 years. Primary care physician, see people with chronic cough. It was my job in our primary care group practice to handle controlled medications. So that was part of my responsibility. So I treated 29 people, half black, half white, almost split perfectly 50-50 because that's how our demographics are. I was charged for prescribing to 4 black men and nothing said about any of the white patients, the same age group, everything the same. When the pain committee in my state had reviewed this prescribing, and why the pain committee is reviewing cough treatment is interesting, but they had underlined the word black, prescribed to black men. And it became obvious to me that there is, implicit or even explicit bias taking place here, where depending on someone's race, you can't treat them with a certain medication without being perceived as being a bad doctor. You're enabling diversion or you're enabling addiction. And this is true in pain treatment in general. We've seen where there was an African-American woman who died in a hospital because after a C-section, she was saying, I'm in pain. And they were saying she just wants pain medicine. She ended up having a complication that ended her life. People, you are supposed to assume, based on the color of someone's skin, how much pain they're in. You see it with Native American treatment too. They'll say, well, Native Americans are stoic, they're tough, they don't need pain treatment. All of humanity left on this planet, we don't have any Neanderthals or Denisovans running around. We're all the same in a lot of regards. We all have implicit biases. We all feel pain as a species the same, though each individual can feel it extremely differently. But being Native American, you might culturally not show your pain in public as much. You feel it just the same. There's no difference. So there has become a kind of a purge or a crusade to stop the prescribing of codeine with promethazine cough syrup. And the problem I have with the way they're going about it, first, I think it's racist, but even besides that, it's still Schedule 5. Now, Schedule 5 is defined confusingly as being below Schedule 4 in risk of addiction and diversion. Well, then you have to read Schedule 4. Schedule 4 says a low risk of diversion, low risk of addiction. So one part of the federal government labels it as being a low risk of diversion and addiction. Lower than low, actually, because Schedule 4 is low and then Schedule 5 is lower than that. And then you've got another branch of the federal government taking doctors into court and telling the jury that this medication has a high risk of diversion, a high risk of addiction. So we go back to the problems with medical or scientific testimony to a lay jury. You can tell a non-scientifically experienced jury almost anything, and they don't know. They don't know whether that's true or false. They depend upon these government witnesses and experts to tell the truth. And if we are prescribing it and we're looking it up in our, in our manuals and our PDRs, and it says low risk, and we prescribe it as if it were low risk, we should not then be able to be prosecuted by a different branch of the federal government who says it's high risk. It's getting to be such a minefield in medical practice that almost any difference of opinion is seen as a criminal act by either local law enforcement or federal.
Give us a sense of how much codeine cough syrup you prescribe to get the attention.
Okay, so
of the authorities.
Here's what they do. So for my practice, I was the sort of the complicated patient person. So if someone had been treated by a nurse practitioner, which all 4 of these young men had, they'd all been treated by nurse practitioners. They had been to specialists. None of the specialists said they don't have anything wrong, stop their treatment. So they come to me with diagnoses of maybe chronic sinusitis, a cough variant asthma, things like that. And they've been on the medication for around 6 months, each of these 4. So past 90 days, now they're chronic. So the standard treatment is 5 cc's every 4 to 6 hours. Well, if every 4 hours be 6 times a day, 6 times 5, 30 cc's a day. If you're treating them monthly, 30 times 30 is 900. So that's 900 cc's a month. Now, I prescribed less than that. I would usually do it in 600 cc's was, I think, the most I prescribed. So the problem is when you get into court, they will have an expert get up there and say, this is usually prescribed in 3 to 5 day periods. So 5 days of 30 cc's is 150 cc's. Now, first off, the jury has no idea what 150 cc's is. And you want to hold up a little bottle and show them you're not allowed to do stuff like that. So the jury doesn't know what these cc's are. And the expert will get up and say, it is usually prescribed in 150 cc's. Less than 5% of patients are prescribed more than that. Well, that's all true because chronic cough isn't super common. We treat acute cough all the time in the ER. I would do the same thing in the ER, 3 to 5 days, go see your family doctor. These patients have a chronic condition. So they are purposefully confusing the definition of average with common or usual. So if you're outside the usual practice of medicine, right? So everybody who sees the most serious patients is going to be on the extremes of treatment. So nurse practitioners send these patients to an MD because they've said, hey, I've tried for 6 months, I can't figure it out. I would also give them 6 months. So on every one of these patients, I had sent them to specialists, done chest x-rays, looked for tuberculosis. One had spent some time incarcerated. I looked for AIDS, stuff like that. And if I couldn't solve it, I would tell them at the end of 6 months, I'm referring you to a specialist, either a pulmonologist, an allergist, an ENT doctor, whatever I thought was appropriate for what I thought their problem was. And I had said, I will no longer prescribe this medication unless they agree that it's necessary. That was not enough. It was a criminal act to treat them for that period of time. They didn't go back and prosecute the person who treated them before me. But because I treated them, now the person before me, the nurse practitioners before me were treating them 5 to 7 days at a time, which meant the person had to go back 4 times a month, right? I don't think that's reasonable. I think to a degree, of course, they could hammer you for fraud on that too. They would say, why are you treating a chronic problem, right? If you had a patient with chronic pain and you had them come back every week, they're going to accuse you of fraud. You're making them come back for too many visits. So I would treat 30 days at a time, sometimes 3 weeks at a time.
And the only thing that would work would be the codeine-based cough syrup.
It's really the only thing we've got. Dextromethazone is, methazone and codeine are kind of similar molecules. Dextromethazone is the right-handed enantiomer. Dexamethasone doesn't work as well, and it also can be abused. Large doses of dexamethasone can be used as a hallucinogen, and that became popular for a while. And so when you're treating a medical problem chronically, you will prescribe a longer course so that these doses will be high. But what has really irritated me is both in the medical boards and the review committees and it is just assumed that if you're prescribing something to a Black person, they don't need it. Even though they didn't prove diversion, they didn't even claim diversion. They say there is a risk of diversion, therefore you cannot prescribe it. It is criminal to prescribe it. Just like they say there's a risk of addiction in opiate treatment, therefore you can't prescribe. But there's a risk of addiction and diversion with everything you prescribe. There's a risk of death with everything you prescribe. So what they do is over a 2-year period of time, they add up everything you prescribe to every patient, and they say in the newspapers and to the jury, the doctor prescribed a gallon of cough syrup to this man. Well, we don't do that with any other medicine. We don't take your blood pressure medicine and say this doctor prescribed 2,000 pills over a 2-year period. It's numbers without context, and it seems like a lot. And then, but when you get it in context, like when they say 2,000, well, there was a science communicator that was talking about being in a jury, and they kept saying that he had 2,000 milligrams of crack cocaine, right? Well, 2,000 milligrams is 2 grams. That's less than the weight of a penny. But by saying 2,000 milligrams, it sounded like a big number to the jury when we don't deal with,
Sure.
with metric enough that it gives us a common sense. So I started in the medical field 30 years ago, and implicit bias, and now explicit bias, because it's politically popular to be explicit about your biases now, has not gotten better. In a lot of ways, it's gotten worse. Now, I grew up in a former slave state. And when I say former slave state, actually all American states are still slave states, because the 13th Amendment said you can have slaves as long as they were convicted of a crime. So a lot of people think that slavery is banned in America. It's not. The 13th Amendment made an exception for convictions. And if you go down to Angola and Louisiana, it's an old plantation being worked by Black people who are slaves today. They're just slaves who were convicted of a crime. So I don't want to have to practice medicine worrying about the color of my patient's skin, except if it's, related to a condition they might have, like sickle cell or something. But you have to be cognizant of the fact that your colleagues, some of your colleagues, will have implicit biases, and they will see you as a bad doctor for treating patients with darker colored skin with pain medicine or even cough medicine. Your colleagues will have that. Your local law enforcement will have it, and federal law enforcement is clearly enforcing this as some kind of a mandate. And there should be some way to preclude them from doing it, but there's really no one you can go to when when you get targeted like this. So I want to make sure that my colleagues out there practicing and treating cough understand that even though dexamethasone is over the counter and there are only 2 prescription cough medicines that are very effective, Tessalon pearls work a little bit, but there's Hycotus, which is hydrocodone with cough syrup. No one uses that. It really was never very effective. Hydrocodone gets converted into hydromorphone in the body, and hydromorphone is not a good antitussive. But codeine is the best prescription cough syrup, but you should use extreme caution prescribing, or just not prescribe it. Send them to a pulmonologist, send them to an ENT doctor, let them prescribe it.
So what was the outcome of this case? So when you presented these arguments, what was the response to that, and what was the eventual outcome of this particular case?
Well, I was convicted. It's a misdemeanor to prescribe cough syrup to a patient, but I was convicted. If they can get an expert to sit up there and say, this is the usual practice of medicine, and what he did was not usual, then by definition, the jury is going to sit there and look at that, and they're not going to understand, not being medically savvy, they're not going to understand the difference between acute and chronic and subacute and all this. And a lot of it is emotional. So they will throw out large numbers, and that will sound like a lot. And then when you do the math, it worked out to an average for all the patients I treated with cough over that 2-year period. the average amount per month was much lower than the maximum that could have been prescribed. If someone's trying to make money off prescribing cough syrup, first, they're not going to just treat 29 people in 2 years. And they're going to give everybody a maximum dose, and they're going to charge more for the patients being treated with the cough syrup than they do for someone being treated for like blood pressure. But that wasn't the case. The charges were the same, whatever you were being treated for. You came in with blood pressure, diabetes, but that slips right past the jury. You don't have enough time to educate them about these factors, about how you use 3 to 5 days of medication for someone with an acute problem in the ER, and then maybe a week to 10 days when you first start seeing them in a primary care clinic. But when they have a chronic problem, you treat them a month at a time. That's standard of care. But not that many people have that problem. So you will never treat an average patient, and neither will I. There are no average patients. There's just averages within a group. Every patient you see is unique in different ways. And some people can't metabolize codeine. So they will use it up faster than they're supposed to because it's not effective. About 18% of the population, the cytochrome P450-2D6 enzyme does not convert the codeine into morphine. And codeine is not nearly as effective as morphine. So when they come back and say it doesn't work, they're not lying to you. They're serious. It may not work.
Now, if you were to replay this case or your prescription of codeine medicines again, what would you have done differently this time?
I think if they believe that if it's a high risk of diversion and addiction, they need to move it from Schedule 5 to Schedule 3, and that would immediately make all the doctors stop and notice and say why, like they did with hydrocodone, right? They took it from Schedule 3 to Schedule 2, and all the doctors stopped and took a look and said, okay, I guess it's not safer than these other Schedule 2. So they need to change the scheduling. But me personally, what I would do, I would not prescribe codeine cough syrup to any patient for any reason. I would either prescribe them Tessalon, or I would recommend they use over-the-counter things and send them to a specialist. The specialist will be an expert in that area. You as a primary care doctor will not be considered an expert in any area. So anyone they get to come speak against you will be accepted by the court in front of the jury as an expert. And the jury will be told that you're not an expert. The jury will be wondering, why is a non-expert treating these people? Well, primary care physicians should be willing to continue the treatment started by other medical professionals as they make their evaluations and help guide the patient, hopefully, to some form of resolution of their problem. Right. Sometimes you find out that they're smoking. You got to do some checking. You find out they're kind of smoking these, cigar-like cigarettes because they don't think that's really smoking because they do it once a week. That's enough to irritate the throat. And sometimes coughing itself becomes irritating enough to continue the coughing. So they get a respiratory infection. They start coughing. The coughing inflames their throat. The inflammation makes them keep coughing. So you have to use something effective to get rid of the cough, to see if they're just reflexively coughing from the inflammation from the coughing. So you have to use something, or you're not analyzing anything. It could be gastroesophageal reflux at night making them cough. You don't know when it's starting out. It seems simple to someone reviewing it once you know the solution. Just like someone comes in with chest pain in the ER and they end up having an MI. And of course, it seems clear to everybody reading about that later. Well, he came in with chest pain. Of course, he had an MI. Didn't have to be. It could have been a dissecting aortic aneurysm. Could have been gastroesophageal reflux. It could have been esophageal spasm. Could have been a spontaneous pneumothorax. It could have been all these different things that you as a doctor have to evaluate and weigh. But when they Monday morning quarterback it, they can go back and say, well, you should have immediately give him a blood thinner and do this. Well, if he was having a dissecting aortic aneurysm, I gave him a blood thinner. I just killed him. Right? So the medical boards are staffed by physicians. They may not be in your specialty, but they can understand the complications of the care. When you're facing law enforcement, they do not understand anything about that. And to them, it's a simple cookbook thing.
Sure.
And the implicit bias puts you in danger with this cough medication.
We're talking to L. Joseph Parker. He's a research physician. Today's Kevin MD article is titled Codeine Cough Syrup, a Controversial Classification. Joseph, let's end off with some take-home messages that you want to leave with the Kevin MD audience.
Get specialty consultations for any medication that they see as being high risk. So any opiate medication, including this cough syrup, because it is an opiate. So get specialty consultation, get backup, make sure that you have verification and a second opinion on what you're doing.
Joseph, once again, thank you so much for sharing your story time and insight, and thanks again for coming back on the show.
Thank you very much. Appreciate you, Dr. Folk.